Hello, this is Dr. Vomik. Welcome to my pediatric endocrine lecture series for the house staff, regular pediatrician, and the medical student. And this lecture has been designed for medical student who will be taking USMLE, pediatric resident, as they will be going through endocrine clinic rotation as well as the pediatric endocrine board examination, and the general pediatrician who wants to sharpen their knowledge, and is certainly not meant for the endocrine fellows. So I have no financial disclosure to make, and the photograph that may have been in this presentation are completely taken with the permission of the family and in accordance with the protocol of university. And I have no financial disclosure to make. And today we are going to talk about short stature. But this is an outline that I am going to present to you. The factor responsible for fetal growth, the parameters of growth at different age, growth velocity, the factor affecting the normal growth, and the parameters of the growth, short stature, tall stature. Tall stature will not be discussed uh, in this lecture. That will be a little bit different lecture. So let's talk about the fetal growth. Maternal hormone does not play any significant role. We know that if the mother has hypothyroidism or hypopituitarism, the baby born with a rather normal length and the weight. And the baby's hormone also does not play any significant role. We know the congenital hypopituitarism, septo-optic dysplasia, and where the baby does have anterior pituitary hormone deficiency, but their birth length and birth weight does not show any significant changes. It is the placenta which plays a very significant role. The placenta is the endocrine gland for the babies. In utero, placenta has many other functions, as you all know. The placenta makes lactogen, which is also called somatomamotropin, which increase the synthesis within IGF-1, insulin-like growth factor, and that also IGF-BP3 that carries to the site of the growth, and then you grow. So lactogen, IGF-1, IGF-BP3, and the growth. Insulin also play a significant role, and it acts as a growth hormone. How do we know that? Because infant of diabetic mother, if they are not well controlled, lives in the medium of hyperglycemia, and therefore baby is forced to make more insulin. And we do know those babies are born with large for gestational age, and the weight is definitely more than the regular, and at the same time they also develop hypoglycemia later on. The other side is if you have abruptio placenta or small placenta or chronic insufficiency, placental insufficiency, these babies are small. There is one condition of congenital rubella syndrome where rarely there may be congenital diabetes also, because rubella can wipe out all the beta cell, and these babies are also small. So insulin also play a significant role in terms of growth. Now, the parameters of growth is also very important to understand. So we'll be talking in the different parameters like chronological age, bone age, and the height age. Other one that we will be using a lot and very important to understand is the growth velocity. Chronological age is rather easy, like happy birthday. That's your age that you celebrate your birthday. And the bone is very important for the endocrine doctor. This bone is the one that we usually determine before any evaluation of hormone problem. So this is done by taking a picture of the left hand. The standard has been established for the left hand, but right hand they take for the comparison they might take it, but it's the left hand. And usually by using a book or atlas of Gulick and Pyle, which is most commonly used, and we compare the ossification center and how it compare, and then we come up with the bone age. And the height is where your in the growth chart your height corresponds with the 50th percentile. So it could go right and left, and it is on when it is on 50th percentile, and that is the height is, uh, and bone is and height is important, but bone is more important to the endocrinologist than other is. This is not something that you'll be able to see very much, but this is why we take the picture, and there is a Gulick and Pyle method, the book atlas, and we compare and come up with these. Growth velocity is the rate of growth, and it is considered as the most sensitive indicator of child's health. So there are a lot of time as a pediatrician, you might see that parents, grandparents are coming and telling you that baby is not eating anything and throwing everything up. But when you put the child or baby on growth chart and they look very good and they're growing normally, and so chances are they're having adequate nutrition and maybe overeating. So that's very sensitive indicator of child health. In general, that any chronic disease will have impairment of the growth, and that's the bottom line. So another good statement is the irrespective of where your child plots on the growth chart. But if you can show that in the last 6 months, probably better is 1 year, the growth velocity, the rate of growth has been normal, then chances are there is no problem. Chances are there is no problem. It's very important to take the height or the length appropriately. Children under the age of 2, you have to use this measurement box height, and this is what I call kind of torture chamber. Most of the babies will cry because you have to have two people. One is holding the head, another giving pressure on the knee, and then you are holding these two together and then get the length. And after the age of 2, we use this stadiometer, and as you can see that they have to be in right position. The right position is the heel is touching the stadiometer scale, buttock is touching, and the occiput. And slight tilt on the mandible, the upward tilt will be helpful. Majority of the time in busy pediatrician's office, and different nurses are checking the height. If it is not done properly like this gentleman, then you might see the difference. And many a times it is important that if there is any problem with the growth, you need to check it yourself and maybe doing more than one time. In our pediatric clinic, the nurses takes height at least 3 times, and they are they are quite capable and they have trained to do that. So it is very important to do the measurement, especially the height, appropriately. What is normal growth velocity? I have a little formula that I will tell you. At birth, a full-term baby, usually in the United States, we still use inches, is about 20 inches tall or 50 centimeter. At the end of the 1 year, the average growth rate is 10 inches or 25 centimeter. At the end of the 2 years, another 5 inches. So if you remember the formula, 20 first year at birth, and half of these in the first year, and half of the first year's growth in second year. And then from third year, it is 4, 3, 2. And this is the average, and that help you to just remember. But you do have to remember that there is a standard variation, but this is an average. And if you go by the centimeter, that will be the same thing. After the age of 4 years, the growth rate is usually 2 inches or 5 centimeter per year. It could be 4.5, but is usually average is 2 inches per year or 5 centimeter. But minimum and maximum growth rate is ought to be taken into consideration also, because we'll be talking about short stature, familial short stature, all things. But the main thing is that instead of growing 20 centimeter at 1 year of 25 centimeter at 1 year of age, it could be 20 or 8 inches. And a 2 year, instead of becoming 10, it could be 8 centimeter. So these are all lower limit of the accepted range of growth. And this will clearly changes the growth percentile as we will be coming back. And after 4 to 9 is 5 centimeter, but it could be as much as 7, or it could be as low as 4.5 centimeter until they hit the pivotal growth spot. The growth velocity exception is the shifting the growth velocity in first 2 years of life could be physiological. And this thing has to be understood. So that's why in pediatric endocrine clinic, not too many kids are being evaluated before the age of 2 for um, hormone deficiency or growth problem. However, if the growth velocity is really low, then obviously this rule does not apply. So shifting physiologically can occur between 6 months to 2 years, and some endocrinologists believe it might go up to 3. And onset of pubertal growth spurt is variable in boys. They could be early bloomer, they could be in the middle, or they could be late bloomer. But for girls, they have the highest growth velocity just before they start their period. This is the what I was talking about, the changes of growth velocity. See, they have gone up to this, and slowly and gradually they are actually growing at a normal rate, albeit lower limit of the normal, but they has just changes from 50th percentile slowly and gradually to the 5th percentile. And again, weight wise, ideally, this is how it should be, but depending upon how much they are feeding, so this may not be exactly true, but this is how it should be. That's a normal shifting of the growth percentile. The upper segment lower segment ratio is 1.7 in full term baby. And just few things to remember, that upper segment and lower segment is approximately 1 by the time they're 10 years of age. And arm span is equal to the height by also at 10th birthday. And the boys arm span exceed after 10th birthday, and the girl takes a little bit longer, is about 14th birthday. But this, for a general pediatrician or the endocrinologist, is not as important to remember all this part, but do remember that the growth velocity. The birth weight is again in about 3.5 kg or 7 pound 8 ounce, and usually the infant fed properly and without any organic condition or any disease, they double their birth weight by 4 months, and the triple by the age of 1 year, and subsequent weight gain is 5 to 6 pound per year, but that also depends upon the how much they are feeding. It could be more, but ideally it should be 5 to 6 pounds. So when you see a child with short stature, then how do you classify them? Different endocrine clinic and different endocrinologists may have their own way, but I found this has been helpful to me. I call primary growth deficiency, and that in that category you can have intrinsic defect in the skeletal system like multiple epiphyseal dysplasia, achondroplasia, the disease of the bone and cartilage. The potential for normal growth is impaired, and the bone age is not delayed. If you check, the bone age will not be delayed. And in that area that I have said, that skeletal dysplasia, but the chromosomal anomalies, and the most common one is your Turner syndrome, Noonan syndrome, intrauterine growth retardation, and some of the syndrome like Purzeria, Russell-Silver syndrome, Prader-Willi syndrome, and Noonan's syndrome as mentioned, and they may have primary growth disturbances. Secondary growth deficiency, when the etiology is outside the skeletal system, they usually have delayed bone maturation, and potential often exist for good height. So either by nutrition or the hormone, but the potential is very much there. The secondary disturbance of the growth is number one is undernutrition or the disease of the gastrointestinal system, inflammatory bowel disease, celiac disease. Kidney always have to be kept in the back of your mind. If somebody has renal tubular acidosis, Bartter syndrome, glomerulonephritis, that will interfere with the appropriate growth. Congenital cyanotic heart disease, you have interference with oxygen delivery to the tissue so they do not grow. And the other one is psychosocial deprivation. Nature and nurture. A baby may born normally, but if they have no proper parental care, then they don't grow properly. The best example that is, I remember when the communism fell and the Romania, there are lots of children and the babies was in orphanages. And there you could see those children are underweight and they were not growing properly. But once they were put in an environment of caring, nature or nurture, what you call, they grow. They don't need any other thing excepting proper nutrition and care. As you can see, the metabolic and endocrine disease is right here, down below. And that's really where it should be. So what is short stature? Well, without having a great definition, we can go by if your height plot less than 2 standard for age and sex, that's short, and more than 2 standard, they can be called tall stature. But I'm not saying they are abnormal, but this is how we have been defining. And this is the diagrammatic representation. The most common organic cause of short stature, most common non-organic cause of short stature, non-organic cause of short stature is familial short stature. Also, they would like to call as a genetic short stature. The other is constitutional delay of growth. Next slide is so important. That's what I have elaborated this slide. If you just some way or other can capture this one and the next one, you will be able to answer the most common question they ask in your pediatric board. So familial short stature, you can see they are born with normal length and normal weight, and the growth velocity decline between 6 to 24 months. And growth rate is lower end of the normal, not abnormal, but lower end of the normal. And I have put the star, and that's what it will differentiate between the next slide when we'll be talking about constitutional delay. Family history is positive for short family member. It could be parents, but it could be uncle or aunt or grandparents. So that don't stop just by getting the history of mother and father. Ask about uncle and grandparents as well. If you do the laboratory evaluation, that will be unrevealing. It will be normal. Most important is that if you do the bone age, is going to be identical with the chronological age. Identical with the chronological age and normal timing of the puberty. My puberty lecture that I will emphasize to you the pubertal hormone. They listen to the bone maturation, not your birthday. So since the chronological age is normal, the timing of the puberty is also normal. And adult stature will be pretty much consistent with the family height. And if you do the laboratory finding, check the lab, then they will have normal laboratory evaluation, and bone age is delayed. And some people feel the bone is equivalent to the height is. The puberty is delayed because the bone age is delayed, and the assurance is most important. But sometimes this family has a hard time to accept, and these are the one uh, the growth hormone has been used by some pediatrician. I'm a pediatric endocrinologist, and it is of questionable value. So this is a growth chart, which comes in your exam also. This is no difference until they hit puberty. The growth rate is low, normal. But coming here in familial short stature, they have started puberty and they end up in closing their epiphysis early, so they will be about right here, 5, 6. But this one will keep on going, and so end up in pretty tall or definitely familial height. We frequently ask by the parents, is there any way we can predict the adult stature of this child? Well, there is a formula I'm going to share with you, but it's not always 100%. But let's see that. This is how we do the boys. We take the mother side in centimeter. Somebody can do it in inches also, and add 13 with that, and then add the father side and divide it by 2, and we give about 5 centimeter plus minus. For girls, we take the father height minus 13 plus mother height and divide it by 2 plus minus 5 centimeter. Now, from where this 13 centimeter came, and that sometimes people don't know, but I just want to tell you this, that in this country, in a Western society, it is believed the average height difference between men and women is 13 centimeter. So that's how they can have come up with 13, not unlucky 13. Endocrine cause of growth disturbance, obviously growth hormone deficiency, hypothyroidism, gonadal dysgenesis, as we have talked about, Turner syndrome, Cushing syndrome, pseudohypoparathyroidism, poorly controlled diabetes, and premature epiphyseal fusion that you see in precocious puberty and congenital adrenal hyperplasia. Although before puberty their growth rate is high and their bone age is advanced, so they look tall person, tall child at the age of 4 through 10, but after that their growth rate more or less timid because the bone is going to fuse pretty early. So in the beginning they look tall, but at the end they end up in being short. And in any time that if you see some growth start like this is really abnormal. And from here onwards, one has to pay attention right here. They are not supposed to do that. If this is pathological, and that has to be addressed immediately. And again, as you can, the failure to thrive for nutritional reason, it is the weight which falls first and the followed by the height or length. and downward crossing of the percentile after 2 years, and the significant changes of the growth rate. These are all warnings for the potential growth problem. And I think this is a very good statement. If the height is minimally below third percentile, and if the recent growth rate is normal, 6 months to 1 year, and if the parents are relatively short, then intensive evaluation is justifiably delayed and follow the growth rate. The following minimum investigation may be a good idea for the short stature, and you get the good history, and as we have mentioned already, good physical examination to rule out all the major disease of the organs. And this is where you have to also measure the proportion of the body. Bone age determination is very important. If the bone age is identical with the chronological age, the endocrine cause is very, very less likely. Any short girls come for the evaluation. The one thing has to be done is the karyotype. Because we know 15 to 20% of the Turner syndrome, they may have no clinical features that we have read or we know in Turner syndrome. Only thing they may have, delayed puberty, no puberty, and short stature. So for the girls, karyotype, for your purpose of the exam, karyotype is very important. Electrolyte, CBC, and the chemistry profile is always a good idea. Always do the thyroid function test. So that easily available, and if the thyroid is not functioning well, hypothyroidism, then you have your problem identified and it's easy to take care of that. Then do the IGF-1 and IGF-BP3 also if you're doing that. And most important is the follow the growth percentile, growth velocity, growth rate every 6 months. And this comment was made by Dr. Tanner in Great Almond Children's Hospital in London. And he said, if it is determined that a short child is an appropriate candidate for endocrine evaluation, this is best accomplished and more efficiently done by obtaining is a pediatric endocrine referral. Well, the this is a very valid statement, but there are times that when your endocrinologist, the near ear area is very busy, and you might consult them and he or she might suggest you. So these are the tests you do, and that is also very acceptable. The other time it is acceptable is that if the family is having significant psychological problem regarding short stature, and they probably would like to hear from a specialist, and so that is also perfectly appropriate in that situation to refer, even then you know that you are dealing with probably a non-organic cause. Thank you very much.